So we have a lot. There are a lot of products to offer. There are a lot of options for you and your patients with our devices. So gonna spend some time on cochlear implants, some time on ossia, but as you can see, a lot of implants, a lot of processors, a lot of things available, including historically. So historically, we have developed, I think innovation is a key idea behind Cochlear. We have developed different electrodes to help your patients get the most atraumatic insertion possible. We've developed lots of different implants with the goal that your patients have that implant in their head for their entire lifetime. Reliability is very, very important in that respect to make sure that patients only have to go through that surgery process once or twice if they end up with one in each ear sequentially. And then lots of different processors throughout the years in order to help your patients hear the best way possible. The nice thing is Cochlear always makes sure that our newer technology is backwards compatible, so those patients that were implanted in the 90s are able to utilize the external processors that we have today. So a part of that is going to be getting patients in to see us. So to see qualified audiologists to do that evaluation and make sure that patients are moving from hearing aids when appropriate to cochlear implant devices. So hearing aids are amazing. It's wonderful technology for your patients, but there comes a point when hearing aids just aren't enough. They're not giving the patient the sound quality, the speech understanding that they need and they want. So the point of 60/60 was a big study, Terry Zolan led it, was to kind of see when a good point of referral would be. So when a good position, when you are doing your routine testing that you normally would do with your hearing aid patients, gets to a point where, hey, this patient may qualify for a cochlear implant. Just because they qualify doesn't mean they're going to get one. There are lots of different factors to consider when a patient is looking for or looking into a cochlear implant. Their health, surgically, cognitively, you want to look at their audiogram, all of that good stuff. But kind of 60/60 is a nice guideline to look at. Hey, this patient is kind of getting to that point. Maybe we start that discussion with them. Maybe we start talking about what the next step after a hearing aid is going to be. So when that audiogram is 60 dB or worse, or when that speech understanding is 60 dB or worse, aided or just SRT in the sound booth, we want to consider that. And it may just be mentioning it until it gets worse, and that's okay too. But making it a part of that process, a part of our everyday discussion on the hearing journey with our patients. So management with cochlear implants, we want it to last a lifetime. We want it to benefit them for a lifetime. So if your patient is implanted at 9 months old, we want them to continue using that implant until they're in their 80s. Obviously, updating that external technology and the way Cochlear's cochlear implants work is that outside piece is going to be the updates. So that internal implant is going to remain the same, and we want to make that technology compatible with that internal. So 9 months, 18 years, 50 years, 65 years, want it to stay in their head and patients thrive with that implant. So things that will make that cochlear implant successful for that patient, it's going to start with the surgery. So after they've been deemed a candidate, obviously they get implanted. And we are looking at the duration of hearing loss and when that success happens. And if your patient has been without sound longer, it may take longer for them to succeed with that cochlear implant. So that's why having that conversation early is so important, because patients that get implanted when they're a candidate earlier are going to have a higher potential of doing better. So just like hearing aids, if a patient has not been aided in 10, 20, 30 years and they have a severe loss, the hearing aids aren't going to sound quite right away. So same with cochlear implants. We want patients to not wait that 12 years to get a hearing aid, not wait that 12 years to get a cochlear implant. Earlier is better. Along with the CI surgery, we have our Nucleus Smart Nav system. So Smart Nav is done interoperatively in the OR, and it is for the surgeons and also for you on the back end. So the Nucleus Smart Nav system can analyze time of insertion, how deep it is in the cochlea, Placement check to make sure that there are no issues. We don't want any tip foldovers. We don't want any kinks or anything like that in the electrode array that's going inside the cochlea. It also does impedances and NRT, so that neural response telemetry. It is an app, which is nice because we can add on things in the future. So we have already added on, in addition to auto NRT, you can now do advanced NRT in the OR, and you can do ESRT in the OR. So that information is great for audiologists to help program that device to the best ability on the back end. We have lots of different electrodes, so Cochlear is about choice and using the preferred electrode, because we want our surgeons to have what they are comfortable with and what they like to put it in our patients' ears. But we do know that scala tympani placement is ideal for our patients. We obviously want it there, not anywhere else in the cochlea. So there have been lots of studies lately. This one is by Holden et al., looking at placement of the electrode and outcomes. So obviously, if the cochlear implant is in the right place, patients are going to do better. And the way that we facilitate this is by having a nice, small, thin, atraumatic electrode going inside the cochlea. Also, we want to use what your patient has. So if they have residual hearing, we have a hybrid option. So that is utilizing the acoustic component with the Nucleus 8 processor in order to boost those lows if your patient still has them, while stimulating electrically with the electrode array. There is kind of a sweet spot for that. So we have different algorithms in the software to allow for overlap between that electrical stimulation and acoustic stimulation in order to get your patient to have that full sound quality. Proximity to the medalis is important. So if that stimulation is close to the nerve that we want to stimulate, patients are going to do better. So we have developed electrode arrays for that as well. Also, with technology these days, we never know what the future is going to bring up and going to become. So of course, we want our electrode to be as small as possible and not ruin any cochlear structures, just in case something can happen in the future. So with that, we want the cochlear health to be as good as possible. So we want to have as little trauma with our electrode going in there and make it as sealed as possible post-implantation. So most surgeons will implant in the round window in order to keep everything nice and tight and together, pack around it, keep everything enclosed, and keep any inflammation, any trauma from happening inside that cochlea. So again, design matters. What we're doing at every step of the journey matters. Slim Medalar is our current electrode. We also have the Slim Straight and the Contour Advance if needed. We have a Smart Hearing Alliance with Resound. So Valerie did a great job talking about Bluetooth Low Energy. Our Nucleus 8 processor does have the ability to utilize Bluetooth Low Energy. So when those billions of devices come out, Auracast will be available for your cochlear implant patients. So really exciting stuff. Satisfaction. So I get this question quite a bit from patients. Do cochlear implants work? Yes. If you are a cochlear implant candidate, a true candidate, you're going to do better with a cochlear implant than with a hearing aid. Just having that direct stimulation to the nerve is going to help. Of course, earlier is better once they get that candidacy. So there are different factors that will have a patient do better or worse. Kind of think of their potential. If they have things stacked against them, their potential may be a little bit lower. But if we get that patient that has been through the hearing aid journey, is maybe on their 6th, 7th pair of hearing aids, and just keeps coming back to you saying, I can't hear well. Like I've tried all of these, I'm just not doing well. And they kind of meet that 60-60 criteria. Maybe it's time to see if a cochlear implant is the appropriate next step for them, because their outcomes could be amazing. Okay, so switching gears in the last 4 minutes, talking about bone conduction. So we have two things going on. So we have cochlear implants, amazing technology, and then we also have bone conduction. So that's going to be our Baha and Ossia implants, which has come a long, long way since Cochlear acquired bone conduction in the early 2000s. So lots of developments. There are really three options with that. So we have a non-surgical option, so that's going to be our soft band or sound arc. We have our active bone conduction, so that's going to be our ossia device. So the transducer, the part that vibrates, is going to be in the implant under the skin, and then the patient wears an external processor. And then we have our BAHA, so this is going to be the connect system or the attract. I think with ossia, it's mainly the connect, so this is the abutment, and then the bone conductor is on the outside with the BAHA processor. Our newest bone conduction is going to be the ossia, so the OSI 300 is our new ossia implant. This implant is really, really cool because it will deliver really great sound quality to your patients from under the skin. So minimal drilling for your surgeons. They already know how to put in a BAHA implant, so it utilizes the same exact implant. So it's really straightforward surgery for them. They kind of already know the steps. And now it's MRI compatible. So that magnet is going to be similar to the magnet utilized in our Nucleus systems. So in our cochlear implant side, we also have that MRI compatible magnet, so patients can get an MRI up to 3 Tesla without head wrapping or anything like that necessary. Now we've carried that over to our bone conduction side with the ossia, so patients can get that 3.0 Tesla MRI without head wrapping or anything like that. So as MRI becomes more and more prevalent and kind of the gold standard of scans, we want to make sure patients have access to that. It utilizes a similar external processor. It's not the same. Think purple. Stop by the booth if you want to see what I mean, in order to get that sound through to the patient. So, kind of wrap up. Nucleus 8 and Canzo 2, our off-the-ear processor, are going to be our two cochlear implant side processors with our CI 600 implants. So that's going to be the scala tympani inserted implants with the slim dialer and some straight electrodes. And then our bone conduction side is going to be our BAHA and our ossia implants. So two great solutions for your patients to ideally get the best sound quality that they can with whatever they have going on each side. So please stop by the booth and I can tell you more, show you more, give you more information, and thank you so much.